Hello everybody and welcome to your screencast on the rest of our respiratory system lecture. So we left off right before we were about to discuss the larynx. And the larynx is found inferior to our pharynx, the laryngopharynx to be specific. And it's made up of a lot of cartilage, but we'll also see a lot of membranes and also some muscles overlying the larynx, as well as mucous membranes covering up the cartilage pieces here. So I want to draw your attention to this hyoid bone. This hyoid bone, if you remember from our skeletal lecture, is a bone that does not attach to any other bone in the body. It's going to be suspended by muscles and ligaments. And so where you would find that is right in this region over here underneath this gentleman's mandible. And we have a thyrohyoid membrane that connects it to the larynx. So this is one of the largest, I shouldn't say one of the, it is the largest piece of cartilage that we're going to find within the larynx, and that's our thyroid cartilage. And another piece right below it is called the cricoid cartilage. Posteriorly, we'll also find little other pieces of cartilage. So we're going to talk our way through all of these different components of the larynx, as well as our vocal folds. So we have actually two folds here. So this is our false or vestibular vocal cord or fold, and the one below it is our true vocal cord, or it's also known as your ventricular fold. So a little bit more about our larynx. So this is a sagittal cut through the head and neck, and this is our larynx in this region over here. So our larynx is also known as the voice box, and it is going to extend from our third cervical vertebrae to our sixth cervical vertebrae. So here's atlas, C1, here's axis, C2, so here's C3, and it's at the very top of this cartilage piece called the epiglottis. So that's C3, C4, and C6, and that's about the point of where we see the vocal folds and the bottom of our cricoid cartilage here. So the end of the larynx. We also mentioned that it's going to connect to the hyoid bone. In this picture here is your hyoid bone. And we also have openings to the laryngopharynx. There's my laryngopharynx in green, and it is going to be continuous with our trachea below. So you can kind of see these ridges in here that are a part of the trachea. So the main functions of our larynx is to have a patent airway, to have routes for air and food into proper channels, and also have voice production. And in order to do that, we are going to house our vocal folds. So here we see all of the different hyaline cartilage pieces except for our epiglottis. And so let's go through those cartilage names. We've already kind of mentioned your thyroid cartilage. This is what most people know as your Adam's apple. And the part that sticks out as your Adam's apple is this laryngeal prominence. So this area right in here is the laryngeal prominence. And you'll see that it's kind of shield shaped. All of the anterior portion is all cartilage. But if we look at it posteriorly, I'm going to flip to this picture real quick, it is open posteriorly. If we go back to an anterior view again, we could see our cricoid cartilage here. And this is completely enclosed. So we say that it's ring-shaped, or I like to think of it as it being a class ring, because anteriorly, so if you look at the anterior surface of your hand, our ring is going to be more narrow, whereas if we look at it posteriorly, that cricoid cartilage is much thicker and larger. So you would be looking at the back of your hand and how that ring would look like there. So the other pieces of cartilage are going to be much smaller, and if you were to look at this in a human or in a cadaver, you would see that it is covered with mucous membrane. So you would get a little bit different view of these. So the first one is your arytenoid cartilage, And sitting on top of that is going to be your corniculate cartilages. And then we have your, before we get into epiglottis, your cuneiform cartilages. They're actually up in space within the mucous membrane. So they're not pictured here, but we would find them in this region, and I'll point it out in some other pictures soon. So and lastly, we have this leaf-like epiglottis that is made up of elastic cartilage. Remember that this is going to be the piece of cartilage that folds down to cover the larynx so that food and water do not go down into your trachea and into your lungs. So this is the look that you're going to see with it covered with the mucous membranes. So down here we see your corniculate tubercle, or corniculate cartilage is in here, and that was sitting on top of the arytenoid cartilages that are covered up with muscle right here. And then if we look right above that, these little tubercles here, these bumps, this is the cuneiform cartilage in there. And then we would have a airy epiglottic fold that goes up to the epiglottis and just covers everything in this region. So this is a great picture of your cricoid cartilage showing that continuous ring that it creates. This would be the anterior side here, and this would be posterior. And this is just another view showing how your epiglottis is going to fold down to cover the larynx during swallowing. And something interesting is that it is covered with taste buds within its mucosa, so we can actually have a little bit of a sense of taste here. If we look in the larynx, we are going to be able to see our vocal cords, and your vocal cords are going to have within the true vocal cords, that is. So that's more of this white tissue in this picture. And let me see, this right in here would be your true vocal folds in this one, in which is in the open position. And we're going to have some vocal ligaments in here that will be the core of our vocal folds. It is covered up by the mucosa in this region, and we are also going to see that it's going to attach to the arytenoid cartilages. So the arytenoid cartilages would be in this region over here, a little further down than where my mouse is. And another view of our vocal folds. So this one that is more superior is your vestibular or your false vocal fold. Again, the one below it is your true or ventricular fold. So I always think of these as being in alphabetical order. F comes before T. And some special notes about these folds. Your true vocal fold is, of course, going to be the one that gives us vocalization. But the reason why this fold is called your false vocal cord is because it doesn't produce any sound, for one, but also it instead of that vocalization, it's going to create intrathoracic or intra-abdominal pressure within our body. So we say that it helps to close the glottis, which is the space in between them during swallowing, and that can create, we can use that to create some pressures within our body. Why would we need those pressures? For things like going to the bathroom or giving childbirth. And this is just another view. It is a frontal or coronal cut through the larynx. So this is what we call the vestibule of the larynx with the epiglottis on top. And then these folds here, this one and this one, would be our false vocal fold with the glottis in the middle. And then this in here are your true vocal folds. And you could see that we have some muscles surrounding the true so that it can help control the way we move those folds in order to change the pitch within our voice and loudness and things like that. So below that area, we also have our infraglottic space. And then this is one of my favorite videos to play for you guys, so you could see the movement of everything. Before we watch this, I want to orientate you a little bit. So this right in here, which you'll see moving just a little, is the epiglottis. The white here are your true vocal folds, with the pink on the side being your false vocal folds. And this would be that cuneiform cartilage here. Corniculate cartilage is down here, and back in here, which we don't see pictured, would be where your arytenoid cartilages are. So I'm going to go ahead and play this so you could see those folds moving around.
Now give me a singing. At a low pitch and then sing up. Okay, you go any further? Okay, good. And now high to low.
So here's just another view of how those vocal cords are moving. I know I'm giving you multiple examples and illustrations here. I just think this is such a cool thing within our body. So right here you could see those arytenoid cartilages, and when we open up the glottis in order to breathe, we are going to pull the vocal fold open, and I am just noticing here that this isn't necessarily lined up correctly as far as the labeling. So this back in here is going to be your cricoid cartilage, this purple ring going around, and these string-like structures are representing your vocal folds. So just so you're aware, this is not your vocal fold here, and this is your thyroid cartilage. So when we're breathing, we have this nice and open, and when we speak, we want to move those arytenoids in order to pull those folds in so that it kind of changes the air that is moving through our glottis, and that'll change the sound that comes out. We'll also change it by changing the tension on these vocal folds as well. So you can kind of see that in this picture. Okay, on to the trachea. The trachea is also known as the windpipe, and it's made up of about 15 to 20 hyaline cartilage C-shaped rings that are open posteriorly. So you can see here anteriorly they're nice and close, and I like this cross section image because you see the C-shaped ring here. This would be anterior, and then posteriorly it's open. So what that means is the cartilage ends here, and then this is an attachment to your esophagus. The esophagus lies just posterior to your trachea. So in between these hyaline C-shaped rings, we have dense regular connective tissue sitting in between them, and mostly back in here, and also membranous tissue within the anterior portion. The inner lining of our trachea, which you see a little open section over here, is made up of what we know as respiratory epithelium. And that again is pseudostratified ciliated columnar epithelium with goblet cells. Goblet cells, if you remember, are going to secrete mucus, and that's really important in this area because it's going to trap any debris or pathogens for the cilia to have the time to push it either upward towards the larynx or the pharynx, so that we can cough it out or sneeze it out, or maybe we're able to pull it back and push it into the esophagus to swallow it and have our digestive system kind of take care of it. So as we continue down from the trachea, we see that we are going to make a split here. So this very end of the trachea, it's almost like a V-shaped cartilage, is called the carina. This is where we're going to bifurcate into the two primary bronchi here. And this area is known, if we are have some sensitivity to it or get irritation to this area, then it initiates our cough reflex. Here's just another image to show you that trachea and its relationship with the esophagus right behind it. This is a a nice image where in the yellow we see that C-shaped hyaline ring, and then posteriorly it is open and attaching to the esophagus. And then this image down here just showing you your pseudostratified ciliated columnar epithelium with those mucus goblet cells embedded in there. So this is more of an illustration to give you a clearer view of these structures, whereas this is a real image of human tissue that's been stained for us to see a little bit better. So lightly in pink we can kind of see the cilia in this region, and then these lighter cells here would be your goblet cells, and in the darker pink from here to here, this is your pseudostratified columnar epithelium. This down in here is just some connective tissue. So that brings us down to our tracheobronchial tree. What this means is we're going to learn the branching in which we move down from the trachea and into bronchi, and eventually we'll discuss what bronchopulmonary segments are. So first we just need to know that your trachea comes down and branches into two primary bronchi. Each of those are going to enter into its respective lung, meaning the right bronchus goes into the right lung and the left bronchus goes into the left lung. And then it breaks down into your secondary bronchi, and each secondary bronchi will go into its respective lobe of that lung. So soon we'll learn about lobes, and I'll kind of go into more detail on these. And lastly, we have the tertiary bronchi, and these divide to supply each of the bronchopulmonary segments. So what I mean by bronchopulmonary segments is that your lung is divided into different areas based on where we have a tertiary bronchi entering in. So I have a separate tertiary bronchi for this anterior region, one for this posterior region, one for this superior region, and so forth. So once our tertiary bronchi gives branch to those bronchopulmonary segments, they're going to divide into smaller bronchi, which we call bronchioles. So these bronchioles are going to be smaller than 1 millimeter in diameter. And this is a nice visual down here for you to see what types of tissues are going to be involved here. So you could see the trachea over here, primary bronchus, secondary bronchus over here, and tertiary bronchus. And then from that point on, it begins to become your bronchioles. So as we descend on down, you're going to see that we change the height of our pseudostratified columnar epithelium. We'll start to lose our goblet cells. We also have pleura cells that kind of increase. We're not going to talk so much about them because their functionality isn't completely known just yet. And then we have our ciliated cells will start to diminish, glands will start to diminish, hyaline cartilage, of course, and then we just really have smooth muscle and elastic fibers that are going to be found within the bronchioles. More of the elastic fibers toward the end than the smooth muscle. So now we are going to enter the respiratory zone. So I want to go back real quick. Our tertiary bronchi, we said, gives rise to our bronchioles, and the very last part of those bronchioles is termed terminal bronchioles. At this stage, the air that we're bringing in is only ventilation, meaning there's no gas exchange taking place yet. So once we enter this respiratory zone, what that means is as we get to those terminal bronchioles, we give a branch called respiratory bronchioles. So at the respiratory bronchioles, we can now allow some gas exchange to take place. These respiratory bronchioles are going to have a few alveoli, which the alveoli are the air sacs here. And we need to be in that area of the alveoli in order to allow gas exchange to take place. So from the respiratory bronchioles, we are going to see the alveolar ducts arise from there. And from the alveolar ducts, we get our alveolar sacs. So you should know these structures in order as we descend down into the lungs, starting from the trachea down to the primary bronchi, secondary bronchi, tertiary bronchi, bronchioles, terminal bronchioles, respiratory bronchioles, alveolar duct, and alveolar sacs. So the alveolar sacs are going to have about 2 to 3 alveoli at their end. Remember, we won't have any cilia here, but we'll have some debris that will be removed by macrophages, and the macrophages will move it to any lymphatics that are found nearby or into the terminal bronchioles to get rid of them. So speaking of the macrophages, we need to talk about the different layers within our respiratory membrane because those macrophages will be found in one of those layers. So the image you're looking at here is one of the alveoli. So here is our air sac, okay? And we're going to have 4 major layers that makes up our respiratory membrane. What our respiratory membrane is this wall between the air sac and our capillary. What do we need to go through in order to get oxygen from our air sac into our blood? Okay, so our first layer is going to have a liquid layer of surfactant, and this lines the entire alveolus, as you can see in this picture, this blue line. This is going to be a phospholipid, and its main function is to lower the surface tension in the alveolus. If we did not have this in place, then the alveolus would collapse and we would not be able to bring air into that air sac. So very important function. Next, we have our second layer here. We call this the tissue layer, or I like to call it the cellular layer because we find a ton of different cells in here. So this makes up the majority of our alveolar surface, and it's very thin because we have those pancake-like cells that are called squamous pneumocytes, or they're also called type 1 pneumocytes. So you could see one of these cells here, very flattened out, and then of course we have its nucleus and the other side is flattened out here, and it is meeting at a junction here with another squamous pneumocyte, and these are very thin so that we can move gas easily through this cell. The other type of cell that we are going to have is your type 2 pneumocyte, or granular pneumocyte, or it's also known as your great alveolar cell. And this is the cell that produces the surfactant that we found in layer 1. And it also can help us in cellular repair. The next cell we'll have is the type 3 pneumocyte. It's also known as a wandering macrophage, a dust cell, or alveolar macrophage. So 4 names for this one cell. And this is going to have the job of phagocytosis. So eating another cell or ingesting a foreign particle as they move through the different alveoli. So they're searching for debris or invaders. Another thing I want to draw your attention to is something called pore of Kohn, or the alveolar pores. And these are just openings between the different alveoli so that we can allow these macrophages or type 3 pneumocytes or wandering macrophages or dust cells to move and clean up the different alveoli. So that brings us to our third layer, and that's going to be our interstitial space. So if you remember interstitial space, this is basically meaning the space between the tissues. So it is separating the basement membrane of the, I thought I had an arrow there. It's separating the basement membrane, so I'll use my arrow here, the basement membrane of the alveolar epithelium from the basement membrane of our capillary endothelium. So it's just the very edge here of each of those cells. And it's also going to contain some interstitial fluid. This space is really small, right in here, that our membranes of the alveoli and the capillary appear to be fused. Like you can barely even see this in actuality. In the instance in which we get too much fluid into this space, we would call that interstitial edema, and it would separate it, making this gap larger in here, so it would be more difficult to move the oxygen from the air sacs into the blood, or the carbon dioxide from the blood and the waste products here into our alveolus in order for us to breathe that out. And that brings us to our fourth and final layer, and that is going to be our capillary endothelium, and that contains the capillary blood and red blood cells. So just a quick little overview again. Our first layer has that surfactant within it to keep our air sacs nice and open. Our second layer is our tissue layer that contains all of those wonderful cells, the alveolar epithelium, or our type 1 pneumocytes, the type 2 pneumocytes, the type 3 pneumocytes. And then we have our interstitial space found at the number 3. And lastly, our endothelial layer of our capillary at the number 4. So now let's talk about our lungs and the structure of our lungs. They are the principal organs of respiration. So at the very top, we have the pointed area serving as the apex, and the base would be the inferior portion that is more broad. If we, I thought I had another marker here. We're going to talk about these other structures in the coming slides, so hang on to those. So if we look at a medial view of the lung, we would find this location where we have a lot of structures entering and exiting the lung, and this we are going to call the hilus or the hilum. And this contains, so let me take a step back. The hilus or the hilum is a location. And in this location, we find the root of the lung. So what is the root of the lung? The root of the lung has our vascular and bronchial attachment to our mediastinum. So all of the structures that are entering or leaving our lung at the hilus collectively is found here at the root of the lung. So what are these actual structures? We have one pulmonary artery. We know that our pulmonary artery is going to leave the pulmonary trunk off of the heart. That will bring deoxygenated blood from the heart to the lung. And then we have two pulmonary veins. They are responsible to carry the oxygenated blood from the lung back to the heart, specifically at the left atrium. And we also have one primary bronchus, which is a branch of the trachea and will allow the air to come into the lungs. Note that our lungs are going to be perfused by two circulations. So we have the pulmonary circulation, which we already discussed when we talked about the heart and how blood is carried through the pulmonary artery into the lungs and back through the veins. Whereas bronchial circulation is how the lungs themselves get blood supply and how we bring the deoxygenated blood out of the lungs and back to essentially the heart. So here's a look at our right lung. Our right lung is going to have three lobes. So here you see your superior lobe, or in certain anatomy textbooks they call this the upper lobe. We also have the middle lobe and an inferior lobe, or also known as your lower lobe. Now these lobes are separated by fissures. So we have the horizontal fissure that divides the superior lobe from the middle lobe, and the oblique fissure that's going to divide the superior and middle lobes from your inferior lobe. What's special about our right lung is that it is actually larger, with 66% of our gas exchange taking place here. This makes sense because we have our heart over on the left side of our body. So that leaves less room for our left lung. So our left lung only has two lobes, an upper or superior lobe and an inferior or lower lobe. And that just has one fissure, the oblique fissure, that divides the superior lobe from the inferior lobe. Remember that oblique means diagonal. So this is always going to be the fissure that is diagonal. We also can see a cardiac notch on, over here, on our left lung, and this is a concavity of our heart to fit into. Another special feature of our left lung is this little tongue-like structure called the lingula. Lingula means tongue, so we're going to find this on the superior lobe, and it will hang over the apex of the heart. Let's talk about what components of our tracheobronchial tree are going to supply in the lungs. We talked about how the primary bronchi are going to enter the respective lung, and our secondary bronchi are then going to split to supply each lobe. So we would have one secondary bronchus for that superior lobe of the right lung, for the middle lobe of the right lung, and one for the inferior lobe of the right lung, for example. The tertiary bronchi are going to go and supply those bronchiopulmonary segments. So I like this picture because it shows those tertiary branches going to supply each of the different bronchopulmonary segments, which are colored the different colors that you see here. You will not be responsible for knowing the names of all the different bronchopulmonary segments. Our lungs also have lobules, and these are supplied by our bronchioles and are separated by incomplete partitions. So you can kind of see them in the white in this image here. Next, we're going to talk about muscles of respiration. So when we inspire or breathe in, what's going to happen is our diaphragm is going to contract. And when it contracts, it is going to move from the dome-shaped structure down. So here you see it's a little dome-shaped, but it is moving down. Those fibers will interconnect with one another to shorten, and that's how we get that flat appearance to it. We are going to mostly have quiet inspiration unless you're doing something like exercising. But that quiet inspiration is going to account for 2/3 of increase in size of our thoracic volume. And the inferior movement of the central tendon of our diaphragm and the flattening of that dome will assist in that. And then we can also relax our abdominal muscles. Other muscles that are going to assist with this are the external intercostals, and we'll take a look at that in a moment. We can also use the pectoralis minor and the scalene muscles of the neck that would be in this region here. For expiration, we are going to want to reduce the size of our thorax, so we're going to depress the ribs and the sternum. So the muscles that will be called upon will be our abdominal muscles and our internal intercostals, which I'll show you in a moment. So when we are doing quiet expiration, we're going to relax our diaphragm, meaning those fibers are going to stretch out and we get this dome appearance. So you can imagine by this pushing or pushing up, by relaxing, it's forcing the air out of our body. The internal intercostals will also kind of push down on our rib cage and push the air out of our lungs as well. If we have labored breathing, that means we're using all of our inspiratory muscles, and we want to contract them more forcefully in order to really depress down on the lungs to get that air out. This is just a illustration to give you an idea of what the components of our thoracic cage are doing. If we need to breathe in and increase our thoracic cage volume, then we are able to slightly move our ribs upward, kind of like the handle on a pail. And if we look at the sternum, you'll see that that is moving up kind of like a handle. So it's moving superiorly and anteriorly. Now let's talk about some serous membranes of the lungs. The serous membrane around our lungs is called pleura. So this is going to help divide our thoracic cavity into two pleural compartments. Surrounding the lung itself here in the orange will be your visceral pleura. So viscera, remember, is referring to an organ, so it's right on the organ itself, on the lungs. Surrounding the thoracic cavity is the parietal pleura. Recall that parietal means wall, so this is surrounding the thoracic wall. And you'll see that that's creating a space here, and that is called the pleural cavity. So here's our parietal pleura in blue, and then we have our visceral pleura in orange once again. And there's our pleural cavity, that space that is created with the pleural fluid. This is important because it is allowing for lubrication so that we don't get too much friction between our lung and the thoracic wall, which would be very painful. And this allows an ease for our lungs to inflate and then recoil back down without that friction being present. This is just an image showing you what it looks like when we either get maybe too much fluid within the pleural cavity that causes the lungs to collapse, or maybe we've got some air into this cavity that will also cause the lung to collapse. And just to know what we mean by mediastinum, it is the central region of the thorax that's containing contents of the thoracic cavity except for the lungs. So where the heart lies here, all of this area, this is our mediastinum. Next, we're going to talk about ventilation. We said the term ventilation just means moving the air in and out of our lungs, no gas exchange taking place. So the way we're going to move the air is that we are moving from an area of higher pressure to an area of lower pressure. And if our barometric pressure, meaning the air outside of our body, is greater than the alveolar pressure, meaning the pressure within the air sacs, our alveoli, then air is going to flow into the alveoli. If our diaphragm contracts, like we see in the image here on the left, then the size of our alveoli are going to increase. So you could think of, if our diaphragm is contracting, it's moving down, so it's pulling the air down into our lungs, and we would have to increase our thoracic volume, which means we're moving air into our alveoli, hopefully, and so the size is going to increase. So I wanted to share with you Boyles Law here in order to understand this a little bit better. Boyles Law explains the relationship between pressure and volume of a gas. Gases are always going to fill up a container. It doesn't matter what size it is. These molecules of gas are always going to bounce around and fill it up. And so we have now know through this law that if we are going to have a large volume, then we are going to have less pressure, because now these molecules aren't going to be bouncing into each other as much, and so the pressure in here will be decreased. Whereas if we reduce the volume of an area, that means these molecules have less space now. So now they're bouncing around and increasing the pressure within this area. So they have an inverse relationship to one another. So let's take a look at the pressure changes inside an alveolus. So we're going to call that intra-alveolar pressure. So at the end of expiration, Our intra-alveolar pressure, so we're looking right in here, is going to be equal at 0 to our barometric pressure, meaning the pressure outside our body. So there's no air moving here. During inspiration, what happens is we are going to increase our thoracic volume. So you could kind of see the arrows pushing out to represent that. And we will get an increase within our alveolar volume. So remember, we have an inverse relationship here. So as we get an increase in this alveolar volume, we're going to get a decrease in the intra-alveolar pressure. And so now we get a pressure of -1 here compared to our barometric pressure of 0. So air is moving in at this point. At the end of that inspiration, intra-alveolar pressure is going to be at 0 and our barometric pressure is going to be at 0. So because they are now even, there will be no air movement. Notice that this is an error here. This should say PB, so that's missing here, barometric pressure. And then during expiration, we are going to need to decrease our thoracic volume. So this is going to decrease as well as our volume of our alveolus. So when we have a decrease in volume, that means we are going to have an increase in pressure. So we move up to a intra-alveolar pressure of 1, and this should, once again, a mistake on this slide because of our publishers, and that should be barometric pressure. So that's always going to be at 0 no matter what. And so we will have this movement of air out of the body. So how do we get the volume to change within the alveoli? We need the lung to recoil. And we do this using the elastic fibers within these alveolar walls. We can also use the surface tension or lack of surface tension, our surfactant, to assist us in that as well. So surface tension is the film of fluid that is going to line the alveoli. So where water is interfacing the air, we get polar water molecules that are attracted to one another and will want to pull one side into the other. So that would make this alveolus collapse. But like we said, we have that wonderful surfactant that's created by the type 2 pneumocyte. What layer was that type 2 pneumocyte in? If you said layer 2, you are correct. So that cell produces the surfactant and that keeps the alveolus nice and open. Now babies who are not able to produce surfactant need to be given it artificially in order for their alveoli to stay nice and open, for them to bring in the oxygen and give it to their tissues eventually. So there is this syndrome called respiratory distress syndrome, also known as hyaline membrane disease, and it's common in infants with a gestation age of less than 7 months, where they're not producing enough surfactant to be able to breathe well on their own. Next, let's talk about pleural pressure. Within the pleural cavity, we have a negative pressure, and that allows our alveoli to expand. If that pressure changes, then our alveoli will no longer be able to open up. We need to have the alveoli expand when this pleural pressure is going to be low enough to overcome that lung recoil. Now, I mentioned this a little bit before, but sometimes we can get some air in that pleural cavity, and that is called pneumothorax. So when that takes place, it puts pressure on our lung and will cause the lung to collapse. We've already talked about measurement of lung function, so I'm just going to bypass these slides and come over here to gas exchange. So let's start over here in our alveolus, and we can see within our alveolus we're going to be comparing pressures here. So in our alveolus, we have high oxygen partial pressure of 104. But when we look at our capillaries here, our pulmonary capillaries, we only have a partial pressure of oxygen here as 40. When we look at carbon dioxide, in our alveolus, we have a low number of 40, and in the capillaries, we have a partial pressure of 45. So what our body is going to want to do is move to the area of low concentration. It moves across the concentration gradient. So we want to even this out. And so our oxygen will travel into the capillaries, and now we have in the capillaries partial pressure of oxygen is 104, and our carbon dioxide partial pressure is 40. So as we are moving through our pulmonary veins, we are going to see that, that the oxygen partial pressure is going to drop, because what happens is this blood starts to mix in with the deoxygenated blood that we are draining from the bronchi and the bronchioles themselves. Remember, we talked about bronchial circulation in a couple previous slides. So that's what we're referring to, is draining the lungs themselves, that blood from the lungs themselves. So then we travel back to that left atrium and we pump that blood through the heart, and we can now leave the heart and we reach our tissue where we want to give off oxygen. So this is another mistake. I'm sorry, there's two in this chapter, but this should say partial pressure of oxygen, not carbon dioxide. And so that is set at 95. We want to move it into our tissues, and so we see that this takes place over here as we look at the venule side of the capillaries, and our carbon dioxide is at 40 in the blood, and what we do is we take some of the gas carbon dioxide from our tissues and move it into our blood. So we are set and even here at the venule side of the capillary. That then travels back to the heart at the right atrium, and the whole cycle takes place over again. When we need to modify our respiration, there's a couple different ways in which we can do this, and I didn't want to dive into too many details here, but we're going to be able to use our higher brain centers. Things that will affect it is our speech, our emotions, voluntary control of breathing, and action potentials within our motor pathways. Also, our medullary area, the medulla oblongata, will have special chemoreceptors that are keeping an eye on our pH and carbon dioxide levels. So if we see that we have a decrease in pH or an increase in carbon dioxide, that will trigger our medulla oblongata to cause some changes. We also have our carotid and aortic body chemoreceptors that are not only keeping an eye on the pH and carbon dioxide, but they're also monitoring our oxygen levels. So anytime they see a shift, they will cause a change. And we're going to talk about some of these changes in a moment. We also have a hearing Brewer, I'm not even sure if I'm pronouncing that right, Brewer reflex, in which we have in our lungs some stretch receptors so that we don't overinflate our lungs, and will reduce respiration if necessary. We also have the proprioceptors within our muscles and joints. That information is sensory and will travel into our respiratory centers here in the medulla. And also we have receptors within our skin for touch, temperature, and pain stimuli that will move into the medulla, and that will cause changes within respiration as well. So here are some of those chemical components that will affect ventilation that I mentioned. The chemoreceptors, if you didn't guess by the name, chemo is referring to chemicals. So we're looking at changes in these chemicals within a solution. So our central chemoreceptors, they are going to be sensitive to carbon dioxide and pH, and they give information over to our medulla here in the respiratory center there. We also have our peripheral chemoreceptors that are found in that carotid and aortic body that's monitoring oxygen, carbon dioxide, and pH levels. And that also sends sensory information over, this time into the pons. But we have a respiratory center there too. You do not have to remember these cranial nerves it's associated with, just because we didn't go over and learn the cranial nerves. So when we get an effect of pH, our chemosensitive area of our medulla oblongata, the carotid and aortic bodies are going to be the ones to sense that change. So we will make changes indirectly through carbon dioxide, or we can respond directly to those pH changes. So I like these little charts that kind of describe the changes that will take place. So we're going to start here where this line is representing homeostasis, and we can go in either one direction, right? We could get blood pH that goes up and becomes more basic, or goes down and becomes more acidic. So let's do our pH goes up first. So it's becoming more basic and homeostasis is disturbed. So what's going to happen are the chemoreceptors within the medulla are going to detect this change. Usually it's going to be caused by a decrease in blood carbon dioxide. So that will cause a decrease in breathing or hypoventilation. And so what we will have change is we start to decrease our breathing to increase our blood carbon dioxide, and that will cause the pH to move back down to our homeostasis level. Now if we get pH to decrease or become more acidic, that homeostasis once again is disturbed, and the chemoreceptors in the medulla will sense the decrease in pH, and that's usually caused by an increase in the blood carbon dioxide, and that causes us to hyperventilate or increase our breathing. That increased breathing will decrease our blood carbon dioxide and will move that pH back up to homeostasis. So quickly, we're going to talk about the effect of exercise on ventilation. You guys demonstrated this in our lab in class when we did the jumping jacks and we measured your lung volumes. So you probably noticed that ventilation is going to increase abruptly. So our normal respiration rate, which is the number of breaths that we take per minute, is going to be usually right around 12 breaths per minute, but it could be up to 15 breaths per minute. And so when we exercise, that can go up to as high as 60 breaths per minute. So quite a difference. And this has a lot to do with the movement of our limbs, and there is a learned component to it as well. Ventilation is also going to increase gradually. So we said that ventilation increases abruptly, so immediately increases, but then it will gradually increase over the next 4 to 6 minutes. We also have anaerobic threshold, and this means it's the highest level of exercise without causing a change within our blood pH. If we are doing something like athletic training, we are going to see that the vital capacity is going to increase slightly. Remember, that is the amount of air that we can fully inspire and expire in and out of our lungs. So we don't have a whole lot of control over this, but we can increase it just slightly. Residual volume in that case is going to have to decrease slightly. So remember, residual volume is that amount of air after we've exhaled as much as we can. It's that amount of air that's still left within our lungs that we cannot take out of our lungs, otherwise our lungs would collapse. At maximal exercise, we're going to see that our tidal volume and minute ventilation is going to increase. So tidal volume is that normal breathing in and out that we have take place. And minute ventilation is going to be the breathing that takes place within 1 full minute, as the name says. And then we have gas exchange taking place between our alveoli and our blood. That will also increase at our maximal exercise, trying to bring in that oxygen to our muscles more efficiently. And then we also have alveolar ventilation increases. So when we see increases in alveolar ventilation, what that means is we are going to more efficiently be able to have gas exchange take place at the alveoli, because sometimes you will have ventilation and air moving down to the alveolus, but that doesn't necessarily mean that we are going to be able to move that oxygen into our blood. So with athletic training, we can do that more efficiently and see increases. We're also going to see increased cardiovascular efficiency, leading to greater blood flow through our lungs. And the last thing we'll discuss are effects on aging. It's pretty sad, but at the age of 35 or after the age of 35, we are going to start to see your respiratory system decline. Your vital capacity and maximum minute ventilation is going to decrease. My husband's standing in the corner making a sad face right now. And we're going to see that residual volume, that amount of air left in our lungs after forced expiration, as well as the dead space within our lungs, is going to increase. And we're going to lose the ability to remove mucus from our respiratory passageways, and gas exchange across the respiratory membrane will also be reduced. The good news is you can stop the effects of aging on your respiratory system if you take a couple minutes in your day to practice breathing. So I know that sounds silly because we are breathing all the time, but what you need to do is inspire through your nose for 3 seconds. So let's do this exercise together. And then you're going to hold it for 3 seconds. So 1, 2, 3, and then expire through your mouth for 4 seconds. And then you're just going to do that over and over again for a couple of minutes, and that will help to strengthen your lungs and keep them nice and healthy as you age. So that is it for our respiratory system. Please contact me if you have any questions at all.